So welcome to today's panel presentation examining cancer equity in rural and tribal communities as we celebrate National Public Health Week with various themes hosted by SLM Consulting, the Collaborative Research Center for American Indian Health, and the South Dakota Public Health Association. I'm Melissa Buffalo, lead for the community engagement efforts with the Collaborative Research Center for American Indian Health, CRCAIH for short, and will serve as moderator for today's panel. Thank you for those who are here in person and those who are attending via Facebook Live. Hi! We have 4 amazing panelists from various sectors who all work to support cancer prevention and education in rural and tribal communities. So the first 45 minutes of the panel we'll hear from our panelists, and the last 15 minutes we'll use for Q&A from audience members both in the room and on Facebook Live. So before we dig into the topic today, let me introduce our 4 panelists. Sandy Melstad is CEO, Public Health Consultant of SLM Consulting. Chris Johnson, enrolled member of the Sistine-Wapton Oyate, is a Senior Prevention and Policy Coordinator with the American Indian Cancer Foundation. Lora Black is Senior Director of Clinical Research here at Sanford Health. And David Benson, Executive Vice President for the North Region with the American Cancer Society.
Nope.
No?
That's a different David Benson. Apparently he's easier to find on Google. I'm David W. Benson, the South Dakota Government Relations Director for the American Cancer Society Cancer Action Network. We're the advocacy affiliates of the American Cancer Society.
Yeah, some of it right.
You're not the first or last.
Okay, good. I apologize.
No, it's okay.
So each year in South Dakota, over 4,000 families face the reality of a cancer diagnosis, and 1,600 of our friends, neighbors, and relatives lose their battle with cancer. Cancer is the leading cause of death here in South Dakota and remains one of the leading causes of death, again, among American Indian and Alaska Natives. So as we hear from our panelists in their work in rural communities and with tribal nations, we know about the barriers that can sometimes exist, such as limited access to health care and healthy food, the distance from home to a provider, and sometimes those higher poverty rates. So before I ask the first question, I just wanted to give this quote from a CDC report in 2017 from the acting director, Ann Shushat. While geography alone can't predict your risk of cancer, it can impact prevention, diagnosis, and treatment opportunities. And that's a significant public health problem here in the US. Many cancer cases and deaths are preventable, and with targeted public health efforts and interventions, we can close the growing cancer gap between rural and urban Americans. So again, with the work that all of our panelists do and some of the folks in the room and online do, let's get started with our first question, and this just kind of is geared towards all the panelists, so I'll let you answer as you feel. So addressing cancer is focused across a continuum from prevention to survivorship and through policy. So what are opportunities to reach some of those rural and American Indian populations, and or what barriers do you see with these communities?
Hi, good afternoon, everyone. So my work is with the South Dakota Cancer Coalition and Comprehensive Cancer Program. And when we talk about prevention, and especially when we're looking at American Indian populations, but also rural communities, Melissa really touched on the reality is that we know that, especially in rural communities, which in South Dakota, a lot of our tribal communities are in rural communities, those social determinants of health, those social economic factors are really what are impacting their individuals' ability to be healthy, to have the opportunity to be healthy. And so how we can reach those populations, I think possibly some of our panelists have some other ideas to build on this as well, but certainly we know rural communities suffer from access to care and access to resources. And so those are certainly those barriers. So reaching those populations it's really important. I guess from my lens is always that multi-sector collaboration. And so how can we engage folks from different sectors across the state and across the nation who are working within areas and strategies, initiatives that can really help impact. So community-based prevention programs, community design, so built environments, how can we do economic development to reach some of those populations who are disadvantaged a little bit more. And so so those are just some overarching thoughts from my end.
Hey everyone, my name is Chris. I'm a Prevention and Policy Coordinator with the American Indian Cancer Foundation. And so a lot of the work that we do kind of builds off of kind of the stuff that she had mentioned around prevention and policy, and really gearing all of our efforts toward policy system environmental changes within tribal communities. And so one of the biggest opportunities that our organization really builds on is the tribal sovereignty, and honoring and acknowledging that, and letting the tribes decide really what they want to work towards, and acknowledging that they have the power to build those policies and enact those to improve health and health equity within their own communities. So we just really support that. Another barrier and opportunity that I see with working with tribal communities is gauging the readiness that they are to really do these kind of initiatives, but also to build that capacity, and that opportunity is there to do that. But also recognizing that each tribe is unique, both in their community and in their journey to achieve their optimal health. So our team really values that and meets them where they're at, and makes sure that they're guiding and leading all of the work on their own, and that we're just there to support them. I think that's really important, especially as like an outside organization working with tribal communities, is that they're leading it and we're supporting where they're at and what they're needing, and that we don't come in with our own agenda. And I think that is super important for other people who want to partner with tribal communities. And that kind of gets forgotten some of the times. And so just always honoring that partnership and building those relationships. I was on a webinar a couple weeks ago, and someone mentioned just being a good relative, and I thought that was really important, and kind of stuck with me about how that is so important in the work that we do, is just being there for them and being that good partner, and always making sure that you're sticking to that and respecting them.
Thanks. So when we think about barriers in the context of research opportunities, many of them are similar to other opportunities in healthcare. So when we think about our rural and Native populations, one of the first places that we start is thinking about health literacy. And so really meeting folks where they're at. When we say the word research, I think we're still in a part of the country that there's a little bit of that ick factor associated with the research word. We often hear, I don't want to be a guinea pig, I don't want to receive no treatment, I don't want to, be part of something against my will. All of these things that we've tried historically to overcome within the research world. So, moving beyond just the health literacy and the understanding, then we really get into the pieces where we're talking about, we've got someone from a rural community or from the reservation trying to make their way to a place where a clinical trial is available. And when that's only one place in the state, it really limits their ability to participate. So how do we then spread that network of clinical research sites so that everyone has a better opportunity to participate in those? So whether it's via telemedicine and we reach patients that way, whether it's looking for additional research sites in some of those underserved areas, and we can talk about that later. Just how do we really, again, meet the patient where they are in terms of knowledge and opportunity?
I want to approach this in a public policy sense, in terms of when you're looking at public policy in the cancer lens, and what we do with ACS CAN is really understanding that you have to take a look at not only the state and local level, but also the federal level. And we're dealing with tribal communities and the impact or the relationship of IHS and the work that has to take place with the advocacy and sharing those stories and the challenges and obstacles that are happening in tribal communities to that federal level. And so certainly our organization invests a lot of time and effort to communicate those challenges and burdens, to talk about the experiences of those cancer patients or survivors, to ensure that within the mechanism that's in place, typically through IHS, that those services are acknowledged and hopefully worked on. And then at the state level, working with the state legislature and the governor to talk about the role that they play, and then continue down to the local level. And certainly, as we work on those relationships, understanding that the public policies that we're working on in peer may not always have the impact on those tribal communities due to sovereignty. And a prime example of that is with tobacco control. And as we passed the smoke-free law, that didn't apply to reservations. And so that work needed to continue at the local level. On the flip side, Cheyenne River is a prime example that they were a step ahead of us in incorporating e-cigarettes and vaping products as part of their smoke-free law, that I believe went into effect 2015, that they continue to work and defend. And we at the South Dakota state level we're behind until just last week to finally pass legislation to implement that e-cigarettes as part of the smoke-free law. So for us, it's really acknowledging the different layers and the relationships that have to take place in order to really get to a place where we're making progress, not only in terms of funding with cancer research, but also prevention.
That was great. You guys really set the tone, and now maybe some individual questions, and I think feel free to answer it too. So the first question, thinking Sandy, and I know it's a three-part question, so I can repeat. So understanding those high incident cancer rates within the American Indian communities here in South Dakota, like thinking about what efforts can be taken to promote cancer prevention for these communities, and then what types of strategies can support prevention and reduce that risk.
Sure, great question. So again, I think Chris and I will probably feed off of each other a little bit. So kind of based on what we talked about, so some basic statistics just to highlight for some of you who may not be familiar. So we know estimate about 20% of cancers in the United States are caused by a combination of excess body weight, physical inactivity, excess alcohol consumption, and poor nutrition. And then on the flip side, the World Health Organization estimates about 30 to 50% of cancers are preventable through eliminating environmental carcinogens and modifying our lifestyle behaviors. So we know the literature supports certainly that the health behaviors certainly contributes to chronic diseases, but back to what we talked about earlier, especially when we're looking at rural communities, I think if you get to more to the root cause, we really look at poverty, we look at access to care, we look at access to healthy foods, which I know in rural South Dakota, that's certainly an issue here. Just because somebody wants to be healthy doesn't mean they have the opportunity to be healthy or access to those resources. So when we look at the literature and evidence-based recommendations, which I think a lot of us probably in the room and on Facebook, we know that's kind of a guiding star for the work that we do. But one tool that we utilize a lot with the work I do with Comprehensive Cancer Control Program is Community Guide. So that is a wealth of resources, really looking at community-based resources. So when we're looking about efforts, community-based prevention programs are some ideas that really look to help address some of those broad factors, looking at physical inactivity, poor nutrition. We look at the built environment. So does a community even have resources for somebody to live healthy? I certainly know in the tribal communities across South Dakota, economic development is certainly a challenge, and they may not even have the resources to even have a job. So those are all factors that really are the root causes when we look at some of those other issues that impact health outcomes. Some other things we look at efforts, school-based prevention programs. We certainly know the younger we can start kids to be healthier, the likelier they have to be healthy adults. Worksite wellness programs. David talked about tobacco control programs, which is a big thing in our state as well, and across the nation as well. And then certainly looking at things such as smoke-free policies, community gardens is what is occurring a lot in our rural communities and in our tribal communities as well. So those are just some efforts. I'll keep answering your questions. So then we dig deeper, looking at those prevention strategies. And so as we talked about before, again, the literature shows that social factors are actually the biggest determinant of our health outcomes. So social economic factors. Health behaviors come next, but we again look at those root causes from that social economic factors. But if we look at the health behavior lens, keeping in mind that environmental community access, kind of the key things we look at primary prevention for cancer, looking at physical activity, nutrition, alcohol, sun safety or skin cancer. And skin cancer is actually one of the most preventable cancers out there. And we have a lot of skin cancer rates, not necessarily in South Dakota, but nationwide. And then David again talked about tobacco, but unfortunately the data shows that in South Dakota, cancer is a leading cause of death, and it's lung cancer. And certainly in American Indian population, that affects them quite highly. There's a high smoking rate, not the traditional smoking, but your Marlboros and whatnot. So those are certain opportunities to really look at behavioral programs, support access to physical activity opportunities in communities, access to healthy foods, tobacco cessation. Our state has a really great quit line program, has a pretty high success rate. So that's certainly opportunity with that. And so just some other examples of efforts that are going on in the state to address cancer prevention through that lens. Again, we talked about the Department of Health, the Comprehensive Cancer Control Program, which 3 of us are on this, a small state we mentioned earlier, but looking at it from the continuum of care. And so those are certainly opportunities looking at that multi-sector collaboration. We have a chronic disease control program called Better Choices, Better Health that helps people in their communities manage their chronic diseases. And SDSU Extension is doing some great work in tribal communities. They have been doing that over the last 4 years, but they've actually been on the ground in tribal communities because they have the highest obesity rate. So that's why we're there in those communities. But just like Chris talked about, they're on the ground working with community champions in those tribal communities. They've developed wellness coalitions guided by the community members to help steer the increase in access to physical activity opportunities, access to healthy foods. Community gardens is a big piece of that, being able to be supportive with that. So there's a lot of great efforts going on with that. And then some things just want to kind of point out here, and I know I'm talking a lot, so I'll finish it. So we talked about the cancer program, so that's a great opportunity to get involved. We do have a state cancer plan that goes through 2020, but that really looks at 15 priority areas across the continuum of cancer prevention and control. Then we also have some task forces within that program, which one of the gals in the room helps lead that, but we look at HPV, which is also a preventative factor when looking at cancer, early detection, health equity in cancer, which certainly applies to a lot of the work that we're talking about here today, survivorship, and then data surveillance evaluation and policy system environment change. And so certainly opportunity to get involved with that. And then finally, just want to make sure to mention that they have a lot of great grant opportunities going on in the state that help communities, healthcare systems address cancer prevention and control. So those are certainly something you can look at on cancersd.com. And then finally, they will be releasing a collaborative report through Great Plains Tribal Chairman's Health Board and the Department of Health, and they really looked at American Indian cancer disparities. And so that will be coming in to kind of highlight some of those challenges that may be dealing with our tribal communities, but also relative to some of our rural communities as well. So, so those are just some things to look at from the cancer prevention side. One last thing that we're doing in the state right now, it's called #ThisIsRuralHealthSD. It's a statewide initiative that we're doing right now. That's just a social media campaign. We want you to highlight and share pictures, stories. What does rural health look like to you where you live, and what is important for anybody to know about rural health in South Dakota and how it's impacted? And so, so I'll stop there. But a lot of information about prevention, but those are some feedback for you.
So next question, sorry. So if anyone wants to answer that question, I have another question for Chris that I think Lora could also answer as well. I think is just hearing some of your answers from the first question. So thinking about how can we educate providers to recruit diverse, and thinking specifically about American Indian communities, again, to get screened and why those barriers exist. And then the second one is just kind of tell me about some of the work from ACAF in regards to community engagement. I know you touched on that, and just again supporting that culture as an effective prevention method.
Okay, so I think it's important to first mention what the barriers are, so that it can include things at the system level, so things like inadequate access and availability to healthcare and healthcare services, low rates of health insurance, the high cost of a cancer diagnosis, some of the socio-economical issues that we mentioned already, high rates of poverty, homelessness, and as well as a severely underfunded urban and tribal health system. But then there are also the individual things that we have to think about, like competing survival priorities. So meaning that you might have another health issue that is more important that you need to take care of before you worry about screening. There are also things like taking care of your other relatives that you, say you might be taking care of, like your parents or your grandparents or your child, so you don't have time to prioritize your own health. So you don't have that time to be proactive in your own health, and that time isn't really available. There's also fear of diagnosis, which could stem from low awareness of cancer risk and screening options, as well as we have to worry about the whole the cost issue of the cost of cancer care. There are also cultural beliefs and practices that may conflict with the prevention and screening practices, as well as just the logistical things like scheduling, taking time off from work, busy schedules, childcare, transportation issues. In some communities, they might not have interpreters for those who aren't fluent in English. So some solutions to that It's just let patients know, like when they come into the clinic for something else, that they're due for screenings, and so either getting the screening done while they're there or scheduling it while they're there so that they can know to come back, just so that they're prioritizing that while they're at the clinic. We can provide culturally relevant and appropriate resources and education. So this is a really big thing that the American Indian Cancer Foundation does. We have a ton of resources around both prevention, screening, survivorship, all of that, just making sure that the resources there are culturally relevant, and so that our population can relate to the resources, so we're more likely to pick it up and read it because we can connect with it more readily. We can train our providers to be prepared to talk to our American Indians. So be humble, be present. It's potentially a really big ask to ask someone to get a cancer screening because they're really preparing for the worst, even though that might not happen. So it's just, we need to be able to prepare our providers, of what not to say and how to really best approach the situation. We can tailor screenings to the lifestyles of American Indians, and so we use the colorectal screening as a guideline, or as an example. So we know that colonoscopy is really kind of where we should be going, but if we can get someone to do a stool test at home, that was really an option, and so trying to advocate for that and really supporting them in their health decisions. I have a coworker, Joy, who says the best screening is the one that gets completed. So I really like to follow that. Another really cool solution that I've seen is the multi-generational approaches. So while a youth is in the clinic for a checkup or a screening or whatever they need to do in the clinic, that we are providing them with education so that they can be an advocate for the older people in their lives, and getting them to get screened, and just providing youth with that education so that they're able to just ask their parents or their grandparents to go get screened for this and bring it up and start that conversation young. I think that's really it for that side of it. The cultural piece I can talk about next. So historically, our tribal communities were a healthy people, and at ACAF we really support that culture as prevention model. We're finding a lot of success in that, just because we know that historically we were so healthy that if we can reconnect to those values and those ways of life, that that can help bring up more of the health in our communities. And so we need to support that. And I think a really cool example that we do a lot of work with is around traditional tobacco. And so we know that we have high rates of commercial tobacco use within all of our communities. And so one cool way of incorporating the culture as prevention model is looking at the other side of traditional tobacco and supporting communities and growing their own traditional tobacco, or harvesting that traditional tobacco, and then incorporating the teachings around the traditional tobacco into our commercial tobacco cessation models and all of that education, and showing that we didn't really use commercial tobacco historically, and so just making sure that we're supporting that, and that we can advocate for that in all of our work, and that hopefully other mainstream organizations will support that work as well. That's really it. So.
That was great. I don't know if Laura, you want to bounce off any of that in terms of thinking about the screening barriers?
Sure, when we think about screening Native populations for clinical trials, I think, Chris, you touched on quite a few different things. So if we make a lot of assumptions in that a Native patient makes it to the point where they've had their screening, they have their diagnosis, and they're being seen for treatment, and we have that opportunity, so that kind of golden hour window to evaluate them for clinical trial, it goes back to a lot of the things that you talked about. So cultural mindfulness, making sure that we're addressing any of the myths or the misperceptions that might be out there. And a lot of that really does just fall back to our providers, and making sure that they understand and are comfortable with clinical trials as a treatment option for patients, and not necessarily, a last-ditch effort. Someone who can walk through that with the patient and help them understand that this is an advanced treatment option in a way that they understand and that is mindful of their cultural beliefs.
So Laura, kind of keeping with that, do you want to talk about some of the work within clinical research on cancer and recruitment?
Sure. So one of the areas that we've naturally focused on is recruitment for our rural populations, which include the native populations. This was probably, it might be close to 10 years now, but we did have some federal funding that focused specifically on working with the different tribes and understanding what their baseline knowledge was around clinical trials, trying to develop those culturally sensitive messages. And so we've done some work in that area, but majority of our work focuses on that rural population. So if we think of our primary population as rural, disadvantaged patients in the Dakotas, what we've done in clinical research is, again, try to get the opportunities to the patients. So whether that's working on a telemedicine program where patients can be treated closer to home, they don't necessarily have to have their family member drive them 4 hours for a clinical trial opportunity, and they're able to participate that way. Thinking of things like travel stipends, so let's say that there isn't the ability to offer this clinical trial in another location, maybe it's related to the treatment density, some of the side effect management, or maybe it's only available at certain sites. How do we as a clinical research team think proactively about including travel stipends, lodging stipends, meal stipends, making sure that we provide that patient every opportunity to make the journey to have the treatment at the site that is probably not very close to home. The other thing that I wanted to touch on that I think is really exciting, and it's exciting for all of us, but also really pertinent to our rural South Dakota patients and some of our American Indian populations when we think about the advanced stages at which they present. Not only do they often present at advanced stage of disease, but as we've heard, they likely have a lot of comorbidities. And historically, what that has meant for clinical trial participation is that you aren't included. So diabetes, heart disease, high cholesterol, obesity, some of these things really precluded the opportunity for patients to participate in clinical research. And we were really looking for that well-defined population. And thankfully, there's a national conversation and some efforts around loosening that criteria, because we recognize not only are we not getting the opportunity to some of these populations, but they're also then not being represented in the overall data. And so there was actually, I can send around if anyone's interested, but some publication and some work that was done by the American Society of Clinical Oncology that did get some traction with the NIH. So when we think about our national trials in oncology, really loosening that criteria and offering everyone the opportunity to participate.
Great, thank you. So kind of switching from maybe research to more policy, David. So thinking about, how do current policies in the state affect, again, rural and American Indian populations relative to cancer prevention and control?
I have a feeling I'll be referencing this a lot for this hour. The biggest thing that comes to mind as it relates to policies here in the state that we haven't acted on is Medicaid expansion. And a lot of the things that we've already discussed can tie directly back to Medicaid expansion. And we're at a place where we have to have some political courage at the state level to lean in and say this is the right thing to do, not only for the health of our fellow South Dakotans, for the thousands of individuals, the 13 to 14,000 American Indians that would benefit, but it fiscally it makes a lot of sense. And as we're seeing in states like Nebraska and Utah and Idaho that just put this on the ballot last year and was successful, there's a blueprint there that we need to look at. We also have incredible advantage of, since we're at Sanford, to recognize we have health systems that are working in other states. And when North Dakota has expanded Medicaid and has a very similar population, what's working in North Dakota? What's not working in North Dakota that we can look at here and look to see what it doesn't have to be a North Dakota model or a Minnesota model, or if Nebraska comes together, it can be what works for us here. And I think in my role, that's something that we're going to be looking at, and we have been looking at to encourage legislators and newly elected governor to really take a hard look at what point in time are we truly going to expand Medicaid, and if not, what are we going to do? And when you look at preventive services and our All Women Count program to provide breast and cervical cancer screenings, to those that wouldn't be able to afford it. It used to be one of 3 states, we might be one of 5 states that provides no state funding. That's all federally funded. We did have federal funding for a colorectal cancer screening program, for our Get Screened program. We lost that federal funding, and I believe the state is going to apply for a grant in the coming year for that. So these are 2 clear areas that we're not acting upon at the state level. And when you look at, again, Medicaid expansion, we're paying for expansion as South Dakota taxpayers. Those funds are just going to other states that have expanded it. And right now, with the uncertainty that continues to exist as it relates to the Affordable Care Act, and our organization certainly works every day to protect the provisions that are within that. If we're going to totally get rid of ACA, we need to have a viable option to replace it with. And so at the state level, again, there's been legislation to protect pre-existing condition protections. That hasn't been successful. And so there's been a number of policies that has been brought up that we've taken a hard pass on, and we need to revisit in the next year or 2 to get back to that place. One thing I wanted to bring this up before, and I'll just add it to this. I think there was talk about the smoking rates for the American Indian population to kind of really give that a clear focus. We're looking at a 42% smoking rate for American Indians versus 17% with the white population of the state. I mean, that's what we're talking about when we talk about tobacco control and that disconnect. And now, fortunately, we learned at a tobacco conference last week that the rate has decreased by 3%. We're not really sure what's up with that. My guess is the population is dealing with the rise of e-cigarettes. And we're at a place now with social media and the internet that trend of e-cigarette usage is certainly across the board. It's not just an urban problem, it's across the state that we need to take a hard look at. And so I just wanted to touch on that real quickly. But yeah, I think that's everything I have.
Can I chime in real quick on that? I think this is another interesting update as it relates not only to the American Indian population, but everyone who would be affected by Medicaid expansion. The ASCO group that I mentioned is also doing quite a bit of work at the national level to ensure that Medicaid covers clinical trial participation. So historically, that's been an area where they have not covered. Medicare does. The Affordable Care Act included provisions that require private insurance companies to cover certain pieces on clinical trials. So the gap that was really remaining was in this Medicaid population. So.
And I thought one more thing. One thing that has gotten a lot of attention is the state it has a pending waiver request with CMS to provide a work requirement for traditional Medicaid. That's got a lot of attention recently because a federal judge overturned the Arkansas, and I'm forgetting the other states, Tennessee maybe. But we have a pending request that our state has put forward. And again, for us, we have major concerns about the burden, even though there's an exemption for a number of groups, including cancer patients. But imagine that burden as someone who is dealing with a cancer diagnosis to do the appropriate paperwork, if it is paperwork. And as we're seeing in Arkansas, the huge drop of individuals that are kicked off the program because they can't meet that initial threshold that they'd be exempted from. So we're still certainly monitoring what's happening at the federal level and what administrations can be looking at. But also, I mean, that's what we're doing here at the state level. That hasn't got a lot of attention. That certainly puts a burden not only on cancer patients, but individuals in rural areas that don't have access to a large availability of work opportunities.
I don't know if Sandy or Chris want to chime in, or I have one more question before we open it up.
I'll just chime in from the local level and not from the state level, but and I know Chris and I talked before that we both kind of do similar PSE, but certainly if we're looking at from the prevention side, the local policy is a valuable option and approach as well with some of the communities. We're doing some work with childcare facilities right now, working on childcare policy. So how can you again reach them to children before they get older? And certainly that can be applicable to our rural and tribal communities. And so again, Chris may be able to touch on this too, but I know when we're looking at policy, and especially with prevention, those are what we call health and all policies that does work, and it has a lot of traction from the literature as well. And so looking at it from the lens of prevention all the way up to what David talked about, from addressing folks who already have cancer diagnosis and dealing from that lens too. So I don't know if Chris, you want to build off your policy work.
I guess I can just share some examples of like policy work that we have done at the American Indian Cancer Foundation, some of the efforts that we've supported in the past. So some really cool things around healthy eating is a lot of like the food sovereignty and healthy eating, traditional foods, that kind of work. We've worked with some tribal communities in Minnesota to do like healthy meetings, healthy vending, always supporting indigenous and local foods and making sure that that is served at all of like community events, you know, tribal meetings, things like that. Just always supporting and keeping that tradition and culture as prevention piece in there, and you know, health and all policies like you mentioned. Always supporting that. We've also done a lot of tobacco work where we've a lot of like the tobacco policy, but also ensure that we are including the traditional tobacco aspects of it, and so that we're not just like giving out you know, just regular policies, tobacco policies that don't include that, and so it's always important to keep that in mind. We've also seen a lot of tribal communities include a lot of the e-cigarette stuff, just because we know, or we see the rise in the data and the use of that. So it's interesting to see that a lot of the tribes were thinking about that before that was done at the state level, and so it's really awesome to see that a lot of tribal communities are being proactive in that. So.
So I think we have time for this last question, and I think it kind of hits home when we think about like that personal level of cancer, because I'm sure most of us in this room or online have been impacted by cancer in some way. So thinking about data shows that American Indian women are diagnosed with cervical, colorectal, and breast cancer at a later stage than white women in South Dakota. And I think about like I have two aunts that diagnosed with breast cancer, and thinking about I'm coming up to my mammogram, and it's a scary thought, like, oh my God, like it gives you anxiety. So thinking about for those people that don't work with those rural or American Indian populations through those cancer efforts, like how can they take steps to recruit and collaborate to reduce those cancer incident rates and then promote prevention and control?
So I guess I can start. We're seeing a lot of success with tribal communities, and we talked about this a little bit earlier, with increasing the collaboration within the community through like coalitions and health committees, advisory coalitions, things like that. So we're seeing a lot of success with that, with the work that we're doing at ACAF. So it really encourages that cross-community, cross-sectoral collaboration, but also that community buy-in and making sure that that community voice is heard. So we're doing a lot of facilitation with tribal communities around that, just to make sure that we are honoring, you know, what the community wants and that that engagement is there. I think through the screening side, we're seeing a lot of success with talking with communities and the different programs that are within the communities, and making sure that they're all getting the same message, and so that the consistent messaging is there, and that the screening guidelines are all known, and that say you have like a diabetes program, that they're able to advocate for the people that they're seeing to get their screenings done, even though that their focus is on diabetes, but that they're also incorporating that messaging into their work. And so just throughout different programs within the community, that they're all providing that same message and all advocating for cancer screenings and cancer prevention and things like that. We're seeing a lot of success at ACAF with providing train-the-trainer programs. So through different cancer areas, so breast, cervical, colorectal things, those areas. So just training local tribal members to have that education and knowledge so that they can advocate within their own communities, and in turn have more education for other tribal members.
I'll just talk briefly since I know we're close on time. I would build off what Chris said and even what Lora said too. I think the health literacy piece is really important. I think it's little political, but you know, the immunizations outbreak right now, I think we're seeing that there's some challenges with health literacy out there, and really what the evidence supports that. So I think that is one opportunity. We know education is a big piece of public health, and just getting people to know what they need to do. And certainly, I think back to what Chris said, that community buy-in is very important, but also one of the I do a lot with secondary data and community indicators, and one thing that's relatively new indicator, I think, to measure health outcomes is level of social support. So again, I know within your tribal community and your rural communities, how can you build up that level of social support to get people to understand the impact of health outcomes, but how maybe to get to a screening or get to the healthcare. I'm from West River. My parents go to a rural church, and they're having people who can drive the elderly up to Rapid City to get to healthcare because they can't drive or that type of thing. And so I think those are just some ideas to look about that. So, but I will pass it off to Lora.
Other strategies, I think one of the things that I maybe didn't mention that would be important too and crosses that sector with policy is thinking about some of what other states have done that potentially we could recreate or take note from. The Minnesota state legislature did appropriate a significant amount of money for sites who are willing to target underserved populations. So again, thinking of the American Indian populations, the rural, the elderly, that's really when we think of outside of the American Indian population, generally the Dakotas, our disadvantaged population, considers the rural and the elderly. Again, I think that supports your point, Sandy. So we applied as Sanford and were able to open 2 additional sites. So we had 4 primary performance sites that conducted clinical research in the North Dakota, South Dakota, and Minnesota footprint. Prior to this, we have now opened Worthington, Minnesota, and Thief River Falls. So again, just thinking about how we can work with our policymakers and our other public health professionals to really move that bar forward, try and appropriate some funding, and then when we have the funding, really digging in and understanding what those barriers are on a community by community basis.
I didn't think I had anything to add, but I realized something. Chris, you talked about being a good relative, right? And I kind of want to approach this in a different way of being an advocate for each other. And a lot of the work that we do is spurred on from the challenges that individuals are realizing in their own personal journey or relatives or neighbors. And so when you are thinking about rural communities and just the simple act of transportation and lodging and just the burdens that at that level, and that drives policy that we worked on about 5 years ago, dealing with parity for oral chemotherapies to create that cost-sharing burden where it's not a higher rate than an IV treatment, making it a little bit easier for you to have that treatment at home versus traveling hundreds of miles to get that treatment. Just this last session there was a bill passed regarding breast density notification, and FDA just came out with an announcement that they're going to, I believe, require that nationally. And so by being a good advocate, understanding those challenges of those in your family, neighbors, and bringing those stories to policymakers, so we can start working on that and having that impact, whether it's at the state level, but also the federal level.
Great. I think with that, we have time for questions. I don't know if anyone in the audience has questions or if there's any questions from anyone online.
I have a question.
Yes.
Chris, I don't know if you can talk about any of the policy work ACAF is doing with like tribal casinos and the smoking that still happens there, if you're doing any work there.
So that can be a touchy subject. We realize that, and we really respect the tribal sovereignty, that it's their decision if that's something that they want to work towards. We're there to support them. We've seen some work in Minnesota that we haven't specifically assisted with it, but we've seen one casino that has done that work, but we haven't really been involved in it, and we're happy to help when they do ask, just because it's a driver of the economic stability of like a lot of these communities. So it gets iffy. I'd like to work on that, I would love that, but we really respect the tribal wishes and like what they want to work on, and we're able to support them when they ask for that.
I have a comment, not so much a question, but Lora touched on a lot of work that the American Society of Clinical Oncology is doing, but I do want to add that on April 10th, they are convening a panel of physicians, experts, and community advocates, and the purpose of that discussion will focus on bridging the gap in terms of bringing clinical research in cancer care to rural communities. So ASCO is putting together a Facebook Live discussion similar to this one, and we'll really touch on some of those various financial toxicities and challenges that rural community face in terms of bringing clinical care and cancer research to rural communities. So I can forward you that information to share with the group.
Yeah, and I know we have everyone's email, so we'll definitely share that information if you or Laura want to send it.
Absolutely.
Great.
I've got one more idea. Do you guys have initiatives that target like all levels of school children? I know that like a pre-K or like child care is what you mentioned, so I'd imagine not school-age children, but do you guys have initiatives that sort of target like elementary, middle school, and high school?
Regarding
with
cancer?
prevention? Yeah.
And I have some colleagues in the room, but I'm going to say no. So one thing I think that I've seen over the last few years working on this is that we certainly know that addressing the health behaviors addresses a lot of chronic diseases. So what I think sometimes happens is it gets lumped in to other chronic diseases, and then you don't really pull it out to really focus on it specific to cancer. So the programs that we're working on right now for childcare is, we've had some good success with that over the last 3 years. I actually have to leave to go be on a webinar here in about 10 minutes. We have some funding available for childcare facilities to apply. And then basically I help them develop a policy and they have to implement strategies to address sun safety and UV protection. So looking at that skin cancer prevention level. But beyond that, I guess to my knowledge, and some of the other panel could talk to that, I don't really think the work that I've been involved with or some of the partners have anything very specific to cancer other than the sun safety. It tend to get lumped into the physical activity, nutrition, and certainly those are all strategies that we know that can address this. But I sometimes think that might be a gap in some of the programs that, you know, people forget, like, oh yeah, this, I think they always think about, probably, I feel like they think about heart disease or obesity, those types of things. They don't think cancer. So I think that's certainly a gap, and there's an opportunity to address some of that more specifically. But anybody else, feel free to answer.
Yes.
Hi, I came in late. The event didn't have the correct address on it, but I used to work for IHS in the United States Public Health Service, and the biggest challenge that we kind of had an understanding of was data collection. To get an understanding is, I'm assuming most of you guys, except for you, are on the private sector side. Is there a way that you guys are collecting data and sharing it with because I'm a American Indian and I don't go to private healthcare. I go to the IHS healthcare facility or tribal facility, just because of where the healthcare status is right now. So I don't know. It seems like what we kind of got an understanding back in 2008 is that nobody was sharing data at all. So, and that's a hard kind of cool to do, like at the CDC level, federal level, state and local, and then we have, so nobody's really sharing data. I try to do it as much as possible, but it's hard, just because people have their own agendas and sometimes their outcomes are not that well received.
I would say, so I'm going to narrow it really far. As it relates to clinical research, I know the comprehensive cancer folks are in the room, and so when we think of data in relation to participation in clinical research, there is an initiative there to track where the accruals are coming from, what sites they're coming from, and so we do share that data as a coalition, but beyond that data, I would probably defer to Sandy or Chris.
Thank you.
So some of the research stuff that we're working on at ACAF, right now we are looking at the Minnesota American Indian tobacco use rates. So that's something that we're working on with a lot of the tribes in Minnesota. So we're looking and working with them so that the data is all theirs and that they choose what they want to do with it, where they share it, how they share it, if they share it. I think that's important to note as well. Other things that we're looking at is tobacco messaging, and so looking at if the Keep Tobacco Sacred kind of media campaigns are being effective, and so that's also interesting to look at. But you know, research is such a touchy subject with our tribal communities, just because for a long time, you know, it wasn't the best for us. So I think that, you know, as much as we can to have it tribally led and tribally shared is really important.
And I'll just briefly touch on what I can share and know. And again, there's some health department people in the room who can talk to this more, but I certainly know as far as the work I've done with their state health department and even with South Dakota State University on their projects, they certainly share data in the dissemination of findings. If it's, you know, infographics, reports, that type of thing. Beyond that, to share actual raw data, to be honest with you, I'm not sure to what extent they were doing some of that. I actually am working on a project on opioids right now with some partners, and the way that we've shared data, which will highlight communities and counties where tribal communities are, is you know, conversations. So we are sharing data. It's been part of a project, data sharing agreement, so that is within the people working on the projects. We have had some conversations with tribal communities, but again, back to what Chris said, each community's tribe's different, and they have to decide if they want to share that data. And I know there can be some barriers to that with the tribal IRB and that type of thing too. And so, so that's the extent I can talk to you about what has done. And there certainly may be more level of data sharing from other entities within the state health department, but certainly some barriers to that. But certainly a evidence-based practice that should be approached more. So.
I feel like I could answer that and jump on the panel, but I won't. Jess, do you have any questions? Anyone from Facebook?
We have one question that came in online. It says, Terry Parker, you mentioned that each community is different and will have different needs, which makes sense. What is the best way to get in touch with the various tribal communities to explore what their needs might be?
So for American Indian communities, tribal communities, they often have a health director who can really answer and oversee a lot of their health initiatives, and so that would be the first point of contact that I would reach out to, and then they're able to direct you more to whoever specific needs to help you. So I think that's where I would start.
Yeah, I would agree with that. I think it's each one's different. I know, again, Great Plains Tribal Chairman Health Board, and I think some of them are on the thing today. I know they've done needs assessment in different tribal communities, so certainly there's some other entities we're looking at South Dakota. That could be a point of contact to understand kind of the data collection process they've done to support each individual tribe. And then I know some tribes within themselves, I believe Sisseton, you can correct me if I'm wrong, but I think they have some funding right now to do some of that, or they have in the past to do some needs assessment. So I would echo that. But again, there's a lot of people in the room who could speak to that probably way better than I could. So.
I think in lieu of time, we have about 3 minutes left. If there's any other questions? I have one. So thinking about survivorship, because I know we focus a lot on prevention, and like, what are some ways we can be, like you say, good relatives? Like, how do we help those who are in remission or going through treatment? Like, how, you know, that's a lot for them to deal with, and then thinking about, are they taking care of family and other things within their community? But how can we really be supportive of those going through cancer treatment and that survivorship on a family and community level?
So I don't have the most experience in survivorship, but we have seen a lot of cancer support groups and advocated for that. So tribal communities to have their own, to do what's best, what they think is best. So I think that's also important. But also just providing resources. So at ACAF we have a couple of different, they're more towards nutrition, but how families can support their survivor through nutrition. So just different types of food that they can eat, just gathering around food, things like that. I think having resources available is really helpful.
One area that's American Cancer Society and we on the ACS CAN side have really spent a lot of time in the last couple of years focused on is palliative care and the availability of palliative care. And certainly in our rural communities with having a professional that focuses on palliative care is crucial for the quality of life that individual but also the burden of their family. And so I think having a better, not only the availability, but the training opportunities and education of the general public as it relates to what palliative care is, and then also us looking at states right now. There's a work group of stakeholders looking at palliative care in the state, and so that's really exciting and something that's somewhat new to me as I've been in this role of really understanding what palliative care and really understanding how really in a state like South Dakota that can be so crucial to again allow opportunities for individuals to stay at home, not have to travel, and those additional burdens that can often take place without that palliative care support team.
Great, that was very helpful, thank you. I think with that, I want to give a round of applause to our panelists. Thank you all so much for your time. Just two quick announcements again, and thank you for taking the time to attend if you're in person or online. Just a quick plug for the CRCAIH Summit coming up on April 29th and 30th. You can go to Facebook, CRCAIH, if you want more information, or www.crcaih.org for more information. And then Sandy, you might have more information to add to this. The National Public Health Week has a networking event at Monk's on Thursday if you are in the Sioux Falls area.
Yes, 5:30 to 8. We didn't have a whole lot of people last year, so we want more bodies there. But just a way to celebrate what we all do in public health. And some people may not think they are public health professionals, but the reality is we all play a role in that. And so we invite you to come and just join in conversation networking at Monk's. SLM Consulting and Public Health Association are sponsoring that, and hope to have some of you there.
Great, thank you. And I think just again, thank you to our sponsors for today, SLM Consulting, CRCAIH, and the South Dakota Public Health Association, and again our panelists. So with that, I think we'll end, and thank you guys. You have a great day.